It's my pleasure to be among my colleagues here from, I guess, from interventional gastroenterologists, GI team, and surgeons. So I believe that I'm the only oncologist here today. Well, why we thought about to include this case in the or this part in the discussion today? It's about how we can change drive to see where your part comes to meet us at the end, because majority of these patients, they come toward medical oncology. First of all, I'd like to thank Dr. Imad actually for his great initiative for arranging this first IGCC meeting where we have a collaboration between the interventional gastroenterologists mainly, and then with the other entertaining parts of the multidisciplinary team for treating these patients with the cholangiocarcinomas. So my talk will be focusing about cholangiocarcinoma, immunotherapy, and some of the slides maybe has been repeated by previous colleagues, so I'm going to go on that quickly. So cholangiocarcinoma, unfortunately, it's one of the bad cancers that we deal with all the time. And the main reason why we say it's bad cancer is because we don't have a lot of evidences behind what we're doing. And still, it's one of the deadly cancers that we don't treat them for quite a long time. Unfortunately, these patients, they die quickly. So it's an uncommon cancer, and this is one of the reasons why it's difficult to conduct good studies on these patients. And they're aggressive with very poor prognosis, so patients, they don't survive for a long time. Surgery is the main cure, and I believe this will be very important. Now we pick up cases we don't see a lot of unusual practice. A lot of surgeons now, they tend to refer patients to higher centers for appropriate surgery, so that we're seeing a good outcome, and hopefully in the future we're going to see more early detection on these cases, so we're going to have a better change in the curve of survival of such disease. Systemic treatments is an option, as we heard earlier. Majority of these patients, they come with the advanced disease, so systemic disease in such patient will be quite important. So all of these cases, it's considered to be a biliary tract cancer. However, why we are dividing them? Because the prognosis is different in such patients, as we're going to see earlier. So biliary tract cancer is the majority of the cancer, and the gallbladder cancer are the rare type of cancer. Intrahepatic cholangiocarcinoma, again, it's one of the very rare cancers, as our previous colleague mentioned. So it's not the first part of our differential, as we have a lot of our colleagues from GI fellows here with us. So why, we cannot change the prognosis significantly? Because we have a lot of cases, they present as unresectable disease. We don't have a good evidence about neoadjuvant treatment yet to change unresectable borderline to be resectable. So this is another challenge. And still 5-year survival, unfortunately, for advanced cancer is very low despite all the advances that we have. And this is where we talk about a very deadly disease. So second to pancreatic cancer, gallbladder cancer, or biliary tract cancer considered to be one of the killers in our data. So it is a SEER data, we're saying patient with localized disease, maybe they have a good survival initially, but then all patients who's having regional distant disease, they have very poor survival. So majority of patients will not be there beyond 5 years, and some of these patients, they will not even make it for 1 year. This is a previous slide has been presented by Prof. Hind, so I'm not going to talk about that. So one slide about manageable cancers, how much of patient we see with resected cholangiocarcinomas. Unfortunately, the number is very small. Over the last year, maybe we have only 1 patient that I see compared to another 17 patients who were metastatic that they presented in the last 9 months. So survival, even a resectable cancer, still survival unfortunately is not the best. We don't have a lot of data. Only capecitabine has been shown in the earlier data to be utilized. Some discussion about radiotherapy. Still, there is no final decision about that. But again, the surgical intervention and how accurate surgical intervention, that's the most important. Why we use that. Liver transplant, we had earlier discussion. Maybe the data is not that convincing until now. Is it maybe we have a poor selection? Maybe this is the reason why we don't have a good data about liver transplant. But I think it's part of the future will be in addition to augmenting some new techniques in treating these patients. So unresectable tumor or locally advanced treatment, patients, we have targeted treatments. Now our new things is immunotherapy. So chemotherapy has been the standard backbone of the treatment for such population, and such treatments gemcitabine, cisplatin. We have FOLFOX, and nanoparticle irinotecan is a new kind of standard of care to chemotherapy. Targeted treatment, despite we have a lot of targets, still unfortunately the gears is not moving well toward improved survival. And now immunotherapy, and this will be we have two agents now, durvalumab or pembrolizumab, to be utilized, and this is something to be utilized. CAR T cell, is it going to be changing the game? We're seeing a good results in hematological cancer, starting to come now to solid tumor, but not yet in the biliary cancers. So as we talked earlier, gemcitabine cisplatin has been the standard of care for treating these patients with the chemotherapy backbone, and the main reason why, because that's the best intervention that showed the survival right now. Do we have an evidence that adding additional agent, there's some studies about using 3 chemotherapeutic agents to improve survival, but that was not good. Again, these patients, majority of these patients, they present with obstructive jaundice early, so they need their general condition is not that good, so we need to choose the right patient who we can offer them the chemotherapy. And again, now we have 2 therapeutic, 2 immunotherapy that improve survival. And when we talk about improved survival, we're adding few months to these patients' survival. But again, it's not the big change right now, and maybe this is now the backbone is not the best that we're using. So primary chemotherapy, we're talking about gemcitabine cisplatin, we're talking about oxaliplatin, capecitabine. So multiple chemotherapeutic agents, yet cisplatin, gemcitabine by far considered to be the standard of care that majority of us are using. We have so this is where gemcitabine has been the initial agent that we're using, so was the standard of care initially, then adding the cisplatin improve overall survival, and that's led to the change. We're seeing patients almost reaching 1 year of treatment, of surviving with treating of the doublet protocol of the chemotherapy. And then the immune checkpoint, as hitting all types, we have 2 agents. We have the TOPAZ-1 study, which is a phase 3 study that showed improvement with the survival of adding the durvalumab, and now it's established to be the category 1 in the NCCA guidelines, so it will be considered to be the standard of care. We're using the durvalumab frequently in lung cancer, and now this is the first reduction to be in the biliary cancer. The survival curve hasn't been separated that significantly, but even a minimal improvement by 1.5 months in the survival, that's considered to be an improvement. Yet in the disease-free survival, it has been significantly improved to delay the progression of these diseases of patients. So is all patients are benefiting? And this is where we're waiting for further translational study. Why some patients, they did significantly better than the other, and I believe that's where the further study is going to show which patient will benefit from that. From efficacy point, still persistent data that patient has been followed now beyond 3 years. Some patient they survived, and this is where I believe that initial patient who had a very good depth of response, those are the patients that they do well with immunotherapy. So this is in subgroup analysis, it works in all group in intrahepatic, extrahepatic gallbladder cancer. The gallbladder cancer, maybe the data was a little bit not statistically significant yet, a meaningful improvement as it improved and delay the progression of disease. The second immunotherapeutic agent was pembrolizumab, as it's a different agent, this is anti-BD1, while the durvalumab anti-BDL1. So the pembrolizumab, has been added to the same standard of care of GemCis, and then it showed a similar survival advantage in this population. Maybe the magnitude of benefit hasn't been the best. However, a lot of people has moved to pembro because we have a very good data on using pembrolizumab in other disease site and the availability in other centers. So that's why we use it much more than the durvalumab. Again, the efficacy, we see the magnitude of benefit is a little bit smaller than durvalumab, yet by conclusion it's considered to be the standard of care, as we have a consistent data with 2 immunogenic agents to be added to chemotherapy. What about further line? What to do? We have those patients they have a progression of their disease, and then we go subsequent line. So we use subsequent line of chemotherapy, and patient who use cisplatin gem, we go for FOLFOX. People use FOLFOX, we use different protocol. And again we have the targeted therapy, and targeted therapy is we're trying to target an actionable mutation or specific type of protein in the cell, and that's we'll use an appropriate key for a lock in these this population. We have like, multiple targets, yet like, all the studies showed even there's an improvement, it's only a minimal improvement. Like, IDH1, there's a lot of like, discussion about that because it's a common like, mutation we have in this population, and we have a medication that has been utilized in that. Minimal improvement in survival, yet like, standard of care hasn't been changed to first line yet. FGFR2, now this is like, a new treatment that we're getting also like, in the practices. So all these mutations we have been targeting, still like, mismatch repair, NTRK considered to be very rare, but when patient is lucky to have this mutation, they'll have very like, improvement in the overall survival in this population. This is the timeline of the milestones that we have in improvement in the like, biliary tract cancer or like, cholangiocarcinoma. So you see like, chemotherapy, like immunotherapy has led to a change in the standard of care. NTRK fusion mutation and like, MSI also like, very important change. And now more recently we start to see the BRAF mutation. So we're trying to find an actionable mutation as a standard of care like, to be changed. All the time when we use the, maybe this is like, the last two slides, all the time that when we add a new type of medication, we see a new spectrum of side effects. And I believe now immunotherapy has been utilized in multiple disease sites. So initially maybe it was in cancer practices now for a long time. But now again, we start to see it like, all type of like, diseases now they're using immunotherapy. Keep in mind, like, you are unleashing the immune system of the patient, and once that has been, like, started, you don't know what immune reaction they will develop. Majority of patients, they have a very controlled, like, side effects that we usually manage it very easily, like, with the symptom management, and sometimes, like, we need to hold the treatment. Steroid, like, at a maximum we can use. However, like, we had some fatal cases with pneumonitis and, like, renal failure, yet we are rarely seeing that right now. But all part of the body could be involved, like, as a part of the immune side effect in this population. So in overall, cholangiocarcinoma, like, it's unfortunately is one of the diseases that we need to be very vigilant because we need to capture it early. Unfortunately, like, majority of patients, they present like, as an advanced disease. The use of immunotherapy has added like, even like, a few weeks to survival. However, like, it's a new standard of care in this population, and side effects, we need to be very vigilant in that. Steroid is like, the mainstay of side effect treatment that we are using in this population. However, majority of them, they are very minimal and we can control their disease. And I believe that's my last slide. Thank you all.
So we're going to go through the protocol.